So today we will talk about the fasting during Ramadan, and we know that it's one of the 5 pillars of Islam, and it's obligatory for all healthy adult Muslims. Within the Muslim community, there is an intense desire to participate in fasting, even among those who are eligible for exemption. So if we know that during the last 10 years, a lot of studies had been conducted looking for the epidemiology during the Ramadan time. And Salti and his group from American University of Beirut, they conducted a PGR study, and they found out that almost, let's say, more than 70% of type 2 and less for type 1, almost 40%, they had been fasted for almost 15 days. And further than this, in a CREED study, they find out even for higher numbers for the type 2 patients who fast most of the days, if we can say every day. So basically, what we are looking for, the treatment of diabetes type 2 in Ramadan time, we are looking for avoiding the dangerous complications like hypoglycemia to the level below 70, 3.9 millimole, or hyperglycemia above 300, even than dehydration and probably diabetic ketoacidosis in special groups. And further than this, with the COVID infection, we should be careful from thrombosis if superimposed with the diabetes and during Ramadan. So if we prepare ourselves, we need to keep a plan with our patient. First of all, we should agree management plan for the what we call small objectives. Specifically, we should be reduce hypoglycemia risk during Ramadan, and sometimes we start earlier. Then we need to check the blood sugar by doing self-monitoring of blood glucose and avoiding no hypos or increase in hypoglycemia frequency. And further than this, we should be realistic. We sit to the patient and try to look for his factors rather than only keep our plan. After that, we had to implement our management plan and looking for patients who try to do fasting for a month, and even we discuss after Ramadan for Eid al-Fitr, and going monitoring and support, including the access to local support groups and religious figures, and we plan to mitigate risk of acute complications during Ramadan, including hypoglycemia. After that, we review and agree on management plan. With this, try to, again, assess the patient characteristics and risk stratification. So current lifestyle duration of fasting, physical activity, even including Taraweeh prayers, and nutritional status, and consider comorbidities, atherosclerotic disease risk, chronic kidney disease, and heart failure. Categorize patients into risk groups, and further than this, we look for the age, frailty, pregnancy status in women, and we issue including depression and anxiety around Ramadan. After that, we had to individualize our patient according to the HbA1c, whether the patient is in well-controlled sugar or not, and we look whether he is taking the medication, whether insulin or not, and complexity of his regime. Especially, we will have 2 meals instead of more than, like we can say, 3 meals and 2 snacks, as we advise our patients to have snacks between meals. We should also share decision-making to create a management plan with a family. So basically, we should categorize patients to different groups. One of these groups are the high-risk patients, which this one fasting not recommended. Severe hypoglycemia within the last 3 months prior to Ramadan. Severe hypoglycemia with the average fasting above 16.7 or HbA1c above 10, and history of recurrent hypoglycemia or hypoglycemia and awareness, which is very important for our this category of patients to be avoided. Looking for also for the previous 3 months whether the patient had been suffering from any acute complications of diabetes, like acute illness, or if he's performing intense physical labor, like any active with the hot weather, pregnancy, chronic dialysis, and patients with significant dementia or cognitive deficits. We should look also for high risk. We need which may choose not to fast with the uncontrolled blood sugar, significant micro or macrovascular complications, living alone and treated with the insulin or sulfonylurea, patients with the comorbid conditions that present additional risk factors like stroke, malignancy, renal impairment, or elderly patient. And again, we have a moderate risk group with the group of patients with uncontrolled blood sugar. Further than this, the group with low risk, these people, they can do fasting with the achieved HbA1c control above about 53. They are using metformin, TZDs, or incretin group. So let's start to conduct the what we have from ADA AASD management plan, and we are looking for basically for the treatment group. First group should be the looking for the first line, which is metformin, and with the low risk of hypoglycemia will be fit for patient during Ramadan. If the HbA1c above individualized targets, then we should look for the group of patients with the high risk or established atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. And we consider independent baseline or individualized target HbA1c. Even recently, for the NICE guidelines, they add this group for this category of patients to be a special group to be started with the special indications. And we can also use GLP-1 or SGLT2 if the GFR is adequate, and this will allow in glycemic control. So this is the way how to look for many categories of patients, and we should look for a group which with special indications rather than atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. And this is the group of patients who we are together. We look for to minimize hypoglycemia. So they can use DPP-4 inhibitor, which is neutral also for weight, or TZDs, and SGLT2 inhibitor. So let's say about metformin dose. If the patient on once daily dose, no dose modification usually required. And if he's specifically should take at iftar time, with the twice daily dose, he can take it iftar and suhoor, 3 times combine afternoon dose with the dose taken on iftar, and the prolonged or released metformin, this will be easy way to control. So metformin is the most commonly used first line oral anti-diabetic agent, and severe hypoglycemia and non-fasting individual receiving metformin is rare. So basically, this will be very good choice to continue, especially if the HbA1c well controlled to your patient during Ramadan time. If we go to the second groups, sodium glucose SGLT2 inhibitor, since the last the many updates had been showing that safety of the SGLT2 during Ramadan, including low risk of hypoglycemia and renal safety. So if the patient encouraged to drink a lot of water after fasting, and with the some precautions, be very happy during Ramadan time, and with the added risk protection for atherosclerotic chronic kidney disease. Otherwise, this a lot of evidence for that. If the group for dapagliflozin in a study about 110 patients, randomized open label 2-arm parallel group study in Malaysia, they find that individuals with the any reported event of hypoglycemia about 6.9 in SGLT2 against 28% in the control group, with the minimal non-significant side effect of postural hypotension. So, what other studies? Canaflozine group by Mr. Muhammad Hassani and his group, they conducted a study about 379 patients and the prospective comparative observational study in Lebanon, Kuwait, and UAE. And at the end, 3.7%, if you look for here, 3.7% event in SGLT2 group compared to 13% in sulfonylurea group. And this was significant with the hypovolemia was seen in 16% SGLT2 group and 5% of sulfonylurea group. Canaflozin and dapagliflozin with Alauddin Bashir and his group in 417. Again, they have the confirmed events of hypoglycemia 18.7% with 37% with the patients with the SGLT2 and insulin. Canaflozin, dapagliflozin with the another group in again, it showed that there was a decrease seen in the systolic blood pressure in both groups, but not significant with the benefit, significant difference seen in the hypoglycemia risk. So again, we are looking for our group. This will be fit if the patient, as we mentioned earlier, with atherosclerosis or heart failure, chronic kidney disease, to have this indication. But we cannot start this group on this medication before, at least we need 1 month before Ramadan to start this medication. And even for patients with the chronic kidney disease, we should be more careful according, again, to the GFR indicated to every medicine. If we go to the other group, the risk, which our attempt to minimize hypoglycemia, so it will be DBP4. Sorry, yeah. So this group with the we need to minimize hypoglycemia during Ramadan with the better achievement of HbA1c. Will be good to choose DBP4 or the TZDs. So sitagliptin study had shown also lower risk in comparison with the sulfonylurea, and even in this study there was 6.7% in comparison with 13% in the other group. So AASD consensus recommended DB4 and add option 2, where there is a compelling need to minimize hypoglycemia. DB4 inhibitor are weight neutral and a low risk of hypoglycemia. Another study about vildagliptin, Dr. Munir Al-Uruj and the group, and they have been shown clearly that HbA1c change from the baseline sulfonylurea is associated with a small increase, while vildagliptin was significantly reduced HbA1c if we add it with lower risk of hypoglycemia. And another group had been also shown in another study similar results. So TZD's pioglitazone also will be good choice, is associated with the, usually is not associated with hypoglycemia and is recommended as one of the therapeutic options to metformin to be added in fasting patients during Ramadan, especially when hypoglycemia is a major risk. Additionally, TZDs is an attractive option in lower middle income countries where cost consideration is major issues. TZD should be avoided in patients with history of heart failure. So you can look for the weight increment, which is almost 3 kilograms, and it will be really a significant some side effect in this group, but we will achieve better sugar control and with lower risk of hypoglycemia. As long as we can start, we should be titrating the dose accordingly. Really, GLP group also will be very good choice, and this will be in hereditary group. We can use the GLP and with the significant HbA1c reduction with lower risk of the hypoglycemia with the group of Khalifa et al. And there is no severe hypoglycemia, HbA1c post-Ramadan compared with the baseline, 8 and 7% respectively. Lixisenatide from the same group, they succeed to make almost the reduction HbA1c in both treatment groups from baseline and post-Ramadan period time. So again, GLP group will be a good choice if you compare it with the other choices. If we go now to the cost, we give a choice for the TZDs, but again, we have DPP-4 inhibitor, lower cost than others, and the sulfonylurea to achieve a glycemic target, if not achieve, and the cost is our concept. So sulfonylurea, we have a glipinamide, a glycoside, and a glimepiride, and you can see here in the study the difference between one group and another. Glipinamide is the highest, 25% risk of hypoglycemia, glimepiride 16, and glycoside 14%. So you can titrate accordingly to according to your patients. What we are looking for, this group, especially now in the NICE guidelines, they mentioned to achieve HbA1c of 7 rather than 6.5 in patients using a medication with the risk of hypoglycemia. So our target usually 6.5 if we use very medication with low risk of hypoglycemia, while if we use any medication with the risk of hypoglycemia higher than expected, then we had to titrate our HbA1c target to 7 and according to the age group. So if the patient on sulfonylurea, we need, with the well-controlled blood glucose level, the dose may be reduced. And also the suhoor dose should be, again, reduced. Older drugs like glipinamide, higher risk of hypoglycemia and should be avoided. Second generation glycoside and glycoside MR should be used instead. What about short-acting like ripiglinide? The glimepiride was associated with lower blood glucose level than ripiglinide, and the difference almost was not so significant. But short-acting insulin, secreto, goes just as ripiglinide and netiglinide, stimulate pancreatic beta cells to secrete more insulin, are usually taken before meals in 2 small observations. No hypoglycemic events were reported among individuals treated with ripiglinide during Ramadan. But again, clinically, we should be very careful to choose the dose of this medication, because if you give higher doses, the patient he will even get hypoglycemia during Ramadan time. So other glucose, like alpha glucosidase inhibitor, like acarbose, it will be good because lower risk of hypoglycemia, but in spite of that, we will have another problems like flatulence and GI symptoms, which make it very difficult to use during Ramadan. And the rest of the oral glucose lowering like colbizilam, bromocriptine, and others, we don't have really enough studies to show today. In summary, a pre-Ramadan assessment is vital for any individual with type 2 diabetes that intends to fast and evaluate the risk, educate the patient in self-management of the condition during Ramadan, and to produce a patient-specific treatment plan. There are advantages associated with different treatment options for people with type 2 diabetes, that seek to fast during Ramadan. Individuals taking metformin, sulfonylurea, insulin, secreto or insulin will need to make those adjustments to reduce the risk of hypoglycemia. Individuals on multiple anti-diabetic therapy will find themselves at a greater risk of hypoglycemia. Counseling is recommended if the patient on 3 or more anti-diabetic agents. Dose reduction need to be made to accommodate for increased risk of hypoglycemia. Looking for artificial intelligence and looking for using the Libri will be helpful. Post-Ramadan follow-up consultation is recommended to reassess the treatment regime and discuss fasting experience during Ramadan with the correct advice and support from healthcare professionals. Most people with type 2 diabetes can fast safely during Ramadan. Thank you for listening, and by this I will finish my lecture.